This is you, correct?
Okay. Yes. Okay. Mr. Chairman, my talk today about the postpartum hemorrhage as safe mother life. I cannot speak about postpartum hemorrhage without remember my great professor, Dr. Mahmoud Fathallah. May Allah be merciful for his soul. He was one of the leaders who dedicated his life in all means to improve morbidity and mortality rate in women all over the world. Professor Fathallah, one of his peers, he said, women are not dying because of diseases we cannot treat. They are dying because societies have yet to decide their lives are worth saving. His strategy of Professor Mahmoud Fathallah to decrease the morbidity and the mortality of female in developing countries, 4 items about the poor social causes, the poor social economic development and excessive fertility and high-risk pregnancy and the life-threatening complication. How to overcome of this problem by rising socioeconomic level of women, family planning and community-based treatment service, and lastly, which is very important, the accessible first-level referral service. This is the strategy of Professor Fathallah in treatment of decreased mortalities in female. Postpartum hemorrhage, all of us known about the postpartum hemorrhage, the definitions, more than 500 milliliter following vaginal delivery or more than 1,000 milliliter following cesarean section, or any amount of blood loss within 24 hours after birth, evidenced by a rise of pulse and falling blood pressure. Postpartum hemorrhage affected about 5% of women giving birth around the world. Postpartum hemorrhage in Egypt, it is one important study in 2013 by the Ministry of Health and Population, is about 19.7%. Every 4 to 7 minutes worldwide, one woman in labor dies due to postpartum hemorrhage, or it is complications. They post another study by Professor Dr. Jilani in 2018, the postpartum hemorrhage in Mansoura University Hospital is about 13% of cause of mortality due to postpartum hemorrhage. All of us know the type of postpartum, the primary post or secondary postpartum hemorrhage, but the most causes, about 90% of postpartum hemorrhage are primary postpartum hemorrhage. Bleeding occurs after removal of the placenta, is raw area about 20 centimeter diameter and continues to bleeding. The uterine muscle does not contract and remain relaxed, resulting in what we call the uterine atony. The risk factor, all of us know as a prolonged labor, grand, multiple augmented, precepted labor, history of postpartum hemorrhage, over-distended uterus like microsomia, twins, polyhydramnios, and operative delivery, cesarean section, which is common, or chorioamnitis. Atony is 70% due to postpartum hemorrhage, primary postpartum hemorrhage due to uterine atony. How much time do you have? It is estimated that untreated deaths occurred on average 2 hours from postpartum hemorrhage, 12 hours from antepartum hemorrhage, 2 days from obstructed labor, 6 days from infection. So it is very important we have 2 hours to treat it postpartum hemorrhage to save the mother and decrease mortality. Postpartum hemorrhage after cesarean section is very important. So iatrogenic agents like carbetocin are recommended for routine administration immediately after delivery of the fetus during cesarean section to prevent postpartum hemorrhage and decrease mortality or morbidity. About the secondary postpartum hemorrhage is infection. So the antibiotics in different categories, what is the ampicillin, if there is any sensitivity, clindamycin or metronidazole, or any, and surgical treatment if needed, if any contains remnants of the placenta inside. This is about the secondary postpartum, which is not emergency. The management of postpartum hemorrhage depends on uterotonics, either oxytocin, misoprostol, or prostaglandin E2, and methyl ergometrin, and carbetocin. In Haring, we can compare the advantage of different these uterotonic substances. The optimum treatment should be, number one, longer action, single dose, and the divide of repeated administration, superior efficacy or similar to that of oxytocin, devoid of receptor desensitization, a superior side effect profile over oxytocin. So this is the pharmacological forms of carbetocin and oxytocin. We see here just if removal of one atom of nitrogen and oxygen, and put this at the site of this removal here of nitrogen and atom of oxygen. Versus international bodies and the trials have used recommended different doses of oxytocin. So oxytocin needs in different doses, maybe to 5 international units, maybe increased to 20, to 30, up to 50 international units. So it's a different regimen in use of oxytocin. But carbetocin has been added to the WHO essential medication list of uterotonic. It acts by acting through oxytocin receptors, which causes the uterus to contract oxytocin. So second is uterotonic, and less slight thickening of blood as anti-hemorrhagic. This is the action of oxytocin, different between oxytocin and carbetocin. Oxytocin, as known, the synthetic cyclic peptide from naturally occurred posterior pituitary hormone, binds to oxytocin receptors in the uterine myometer, stimulating contraction of this uterus smooth muscle and increasing sodium permeability of uterine myofibers. Carbetocin, long-acting synthetic analogues of oxytocin with agonized properties, bind to the oxytocin receptor in the uterine smooth muscle, resulting in rhythmic contraction, which is very important, rhythmic contraction, not sustained contraction like methergine ergometrin, but regular contraction or rhythmic contraction. This is very important. And other pharmacokinetic, intravenous of oxytocin action with peak concentration after 30 minutes. But in carbetocin intravenous infusion, one dose contract within 2 minutes, contract within 2 minutes only. Here is 30 minutes, here 2 minutes only, and rhythmic contraction for 16 minutes for carbetocin, and not more than 3 to 7 minutes in oxytocin. And the intramuscular administration of carbetocin, uterine contraction lasting about 11 minutes, and rhythmic contraction for 2 hours. Very important here, the comparison about 2 hours. And the half-life of carbetocin is 40 minutes, but it is a high half-life of oxytocin, 1 to 6 minutes only. Also, oxytocin requires protection, which is very important, from light. Protection from light, and it needs to be transported and stored under refrigerators, 2 to 8 degrees. But the carbetocin is heat stable. Carbetocin does not need a refrigerator. It's very important. The resident can keep carbetocin in his hand, in the bags, at any degree. Many clinical studies comparing the oxytocin and carbetocin and other uterotonic agents, like the systemic review here in American Journal of Obstetrics and Gynecology, preventing postpartum hemorrhage after cesarean section delivery, network meta-analysis for available pharmacologic agent. He conclude in this conclusion in this paper, carbetocin is probably the most effective agent in reducing blood loss and the need for additional uterotonic. Oxytocin appear to be more effective than initial as polls. Here another study, original articles, efficacy and safety of carbetocin in comparison for the oxytocin in active management of the third stage of labor, following vaginal delivery, and open label randomized controlled trials. Conclude, carbetocin appear to be an effective new drug in the active management of the third stage of labor in vaginal delivery. A single dose only is enough. 100 micrograms intravascular of carbetocin is more effective than oxytocin for maintaining adequate uterine tone, and it needed no repeated doses of carbetocin, but oxytocin we needed another repeated doses. Here, International Journal of Gynecology and Obstetrics concluded additional uterotonic were needed less frequent by patient treated with carbetocin, and the carbetocin appeared to be an alternative to compared to oxytocin and misoprostol, where the other comparative versus study of oxytocin for preventing postpartum hemorrhage in patients with severe preeclampsia. This is a double randomized controlled trial. Conclusion, carbetocin is an appropriate alternative to oxytocin for the prevention of postpartum hemorrhage in women with severe preeclampsia. So, carbetocin is superior to ergot alkaloids, methotrexate. Prevention of postpartum, less blood loss after delivery, no needed for additional uterotonic agent, no needed for blood transfusion, less side effect profile. In comparison with misoprostol and other prostaglandin analogs, carbetocin prevents postpartum hemorrhage, less blood loss, and no needed for additional uterotonic agent. A drawback of prostaglandin. This is a second-line agent for treatment of atonic postpartum, needed multiple doses. not recommended till now by WHO, which is very important, associated with a significant increase in vomiting and diarrhea and gastrointestinal symptoms. Carbetocin is contraindicated in these three conditions, the epilepsy, severe preeclampsia and eclampsia before delivery may cause respiratory or cardiac distress in mother and baby. To be used in caution in hypertensive patient. Splendotocin, which is very new drug by Splendid company, compare the oxytocin and splendotocin. Mode of action, synthetic, this is synthetic cyclic oxytocin from posterior pituitary. Splendotocin, long-acting synthetic analogues of oxytocin with agonized properties, binded to the oxytocin receptor in the uterine muscle, smooth muscle, and intravenous act oxytocin 30 minutes. After 30 minutes, here 2 minutes only by carbetocin, and long acting for 40 minutes but the oxytocin just 1 to 6 minutes. Splendotocin prevent postpartum hemorrhage and treatment postpartum hemorrhage and in uterine atony. This is the half-life comparing this splendotocin to oxytocin. And why splendotocin is our drugs of choice for postpartum hemorrhage? Number one, long-acting. It is enough single dose for administration intravenous. No variation in doses regimen. No need for repeated doses. Superior efficacy than oxytocin. Divided of receptor desensitization. Less side effect profile over oxytocin. So, single dose, 100 microliters is enough of carbetocin or splendotocin is enough to control postpartum hemorrhage. This is the package of splendotocin. I think the company will be discuss about the price, the availability in the markets, and I recommended my all house officers and residents to keep these drugs in theater and his bags to prevent morbidity and mortality with postpartum hemorrhage. Thank you very much.
Thank you very much, Professor Ibrahim Mahrous, for this excellent presentation and for presenting to us the studies performed concerning the carbetocin or splendotocin. This drug, I think, it has been recently introduced in Egypt, and I believe it became available now. Before we start the discussion, I would like to thank Splendid Pharma for sponsoring